Someone wanted to know about Pickwick and Pickwickian Syndrome. Pickwick comes from Charles Dickens, the Pickwick Papers, and in that Pickwick Papers there was a character who was pejoratively called the fat boy, but he would fall asleep for no reason, and he had obstructive sleep apnea from obesity, but he also had obesity hypoventilation syndrome, presumably. And so these are related but not exactly the same topic. So in obstructive sleep apnea, you have obstruction of your airway that leads to forced expiratory effort in sleep that causes snoring, and also apneic episodes that cause hypercapnia. This can cause idiopathic intracranial hypertension because of the forced expiratory effort against that closed glottis increases intrathoracic pressure, which is transmitted into your head, but also because of the hypercapnia leading to vasodilation from increased CO2. In contrast, obesity hypoventilation syndrome is not obstructive, and it's not apneic, but it's like hypoxic from hypoventilation. And so it's a similar concept, except it's a central hypoventilation syndrome. So when you're breathing less, that leads to decrease in the oxygen saturation. And so that's one of the characteristics that we're going to see. We're going to see increased CO2, hypercapnia, in both OSA, obstructive sleep apnea, and OHS, obesity hypoventilation syndrome. And both of these can cause increased intracranial pressure, but from slightly different mechanisms. In the obesity hypoventilation syndrome, you have the normal hypercapnia thing, but you don't have the obstructive component of forced expiratory effort against the glottis. And so there's these other things we have to be worried about, which is the bicarb. So you're going to have increases in your bicarb levels in the hypoventilation from the respiratory drive being insufficient. And we're going to have right-sided heart failure. And that right-sided heart failure manifests upstairs as increased venous pressure, and that's what causes the increase in intracranial pressure, but also increased venous pressure in the lower extremities, which is causing the lower extremities to have edema and venous stasis. So you can have venous stasis in your legs, peripheral edema, as well as venous stasis in your head, which causes pseudotumor cerebri. So that combination of fluid behind your eyes and fluid in the sheath and papilledema plus fluid in your legs is going to be right-sided heart problem. So the venous return is impaired. And so when you have a problem with your heart, your core, from your lung, this is cor pulmonale, the right-sided heart failure, and we have to make sure there's no other lung cause like COPD, make sure it's not an obstructive problem, and they're going to do pulmonary function studies that's going to demonstrate a restrictive rather than an obstructive pattern. So it's going to be a restrictive pulmonary insufficiency leading to right-sided heart failure, cor pulmonale, that causes hypoxia and hypercapnia and elevated bicarb, and they might have a secondary increase in their hematocrit, which is polycythemia. So both OSA and OHS have similarities, but they also have differences. The similarities are they both can cause papilledema and mimic pseudotumor cerebri or IIH. They both cause polycythemia, hypoxia, hypercapnia, but in the Pickwickian syndrome, we have this extra thing, which is a restrictive pattern on the pulmonary function studies, oxygen desaturation during the day, and right-sided heart failure leading to increased intracranial pressure from an additional mechanism in OHS versus OSA, and that thing we call the Pickwickian syndrome.